The following program is a production of Pioneer Public Television.
Hello and welcome to Compass, a new production from Pioneer Public Television. I'm Les Heen, your host for Compass, and this is a weekly discussion of public policy and important issues facing our viewing area. This week, we will discuss how rural hospitals are working to improve their outreach programs and improve services for their communities. We will be talking to representatives from the Stevens Community Medical Center and Minnesota Hospital Association later on in the show. First, we have the story of how one associate professor at the University of Minnesota worked with the Stevens Community Medical Center staff to provide a PAD, or peripheral artery disease outreach program, and that's called the Prairie PAD Initiative. Here's Pioneer's Laura K. Prosser with more.
In order to compete with bigger hospitals in the region, rural hospitals have been making an effort to better their outreach programs and the services they offer their communities. Morris and Fergus Falls are two communities benefiting from the first ever PAD Prairie Initiative outreach program.
The PAD Prairie Initiative is a program that is funded by the Margaret A. Cargill Foundation. Our goal is to help people who have peripheral artery disease maintain their independence, live healthier, more functional lives, and this is particularly focused on people in rural Minnesota.
Physicians who work in a rural community, sometimes we work in a vacuum. We don't have a tertiary care facility where we're invited to a lecture on peripheral arterial disease at a grand rounds, and so we miss that. We don't have guidelines thrown at us. We're not sitting in a cafeteria with other specialists who tell us what we should be looking for, what's new. And so having something like this come to our community is just one other opportunity for us to provide the highest quality of care to our patients, care that they might not get unless they live in a big city, but we are bringing it out into our smaller community, and it's a start.
Diane Treat Jacobson is a professor at the University of Minnesota School of Nursing and has been working with PAD for the majority of her career. She knows the pitfalls of working with a disease no one knows about and the importance of spreading awareness around it.
So if you have a disease that nobody knows about, that isn't being treated, and then you have this silent cardiovascular death that's not really attributed to the PAD from the beginning, there's a lack of understanding. So patients, say in the 90s or late 80s, could come to their physician and say, and be diagnosed with PAD or even symptomatic PAD, and they might be told, well, you don't need to worry about this until it gets worse, until you get an ulcer or you need a bypass. The result would be that patients would die of a heart attack or a stroke before that limb outcome happened. We didn't understand that we needed to find it early, aggressively modify the risk factors to hopefully prevent those cardiovascular events.
With this in mind, she teamed up with the Lake Region Healthcare and SCMC teams to educate local physicians and start screenings for the Morris and Fergus Falls communities.
There are many patients who are really interested in coming and finding out if they have peripheral artery disease. We were able to perform a very simple, non-invasive test that diagnoses this condition. It's called the ankle brachial index. It's a simple measurement of blood pressure in the ankles compared to blood pressure in the arms.
Once we have all of our staff trained on doing the ankle brachial indices so that we can do them easily in the clinic, and we have the equipment to do that, any patient that we recognize as being symptomatic or at risk for having this disease will be able to do that screening right there at the appointment. We won't have to wait until we can order it and get them into x-ray and hopefully get the evaluation completed. but we have the opportunity to refer them to the research project where they'll have a supervised exercise program and other opportunities afforded to them as part of the program, as well as long-term follow-up to see how we do.
But the screenings don't just address PAD issues. It's a possible model for addressing all other kinds of community health concerns.
This time we're focusing on one disorder, but this is just the stepping stone to getting the patient in and recognizing that we need to control blood pressure and cholesterol and diabetes to prevent progression of disease and perhaps development of this disease in the future. So if a patient comes in and they recognize that they have the risk factors for developing peripheral arterial disease, even if they're negative on the screen, it's a stepping stone to preventing it in the future, getting us treating those other disorders that might prevent them from developing symptomatic claudication.
This screening was just the start of what people can begin to expect from their rural hospitals as the hospitals work to survive.
I mean, we're still learning what's working, but this could become a model for other kinds of initiatives where it's not the people coming from the city to tell the country what to do. It's coming to the community and saying, I have this to offer. Let me explore with you what works. What do you need? How can we work together to provide that? This model could work for many other kinds of conditions or issues that are facing rural Minnesota. I think it's a wonderful way to combine the strengths of both, to bring it, to raise the awareness, to help teach people how to manage this condition, to give the expertise to the community providers, to give the knowledge to the public. And then it makes each community better able to do this themselves without needing the outside individuals to come.
With us now to talk about the regional efforts of rural hospitals, we have Matt Anderson. He's Senior Vice President of the Minnesota Hospital Association. Also joining us is the CEO of Stevens Community Medical Center, Jason Brewers. Matt, Jason, thanks for coming in.
Thank you for having us.
I'd like to talk first to you, Jason, about Stevens Community Medical Center. So for our viewers who aren't necessarily as familiar with Western Minnesota, tell us where is your hospital?
Our hospital is located in Morris, Minnesota. We also have a clinic that is located in Starbuck, and so we're probably about an hour southwest of the Alexandria area, probably 2 to 3 hours just west of, straight west of Minneapolis.
Okay, great. And Matt, your associations, Minnesota Hospital Association, so you're based in the Twin Cities, is responsible for hospitals all over Minnesota, right?
Statewide, we represent from the very smallest hospital to the largest through the Mayo Clinic on both state and federal issues that affect our members.
Okay. So when you think about your members and you think about the experience at your hospital, what are the biggest changes that are happening in rural hospitals right now? What are some of the biggest things going on?
Well, I think statewide in Minnesota and for a lot of rural communities around the country, some of the biggest changes that are going on are both technology related in terms of electronic medical records, the advent of telemedicine, but also in terms of a lot of the reforms that our communities are going through in terms of health coverage, aging populations, need for services that are local, and how do we maintain those and expand those when there's opportunities.
Sure. So, Jason, if you were to take some of those issues, how do you address all of that? That sounds like a lot. How do you address those in one rural hospital?
I think that's a big challenge for us. But I think one of the things that we do have is a community health needs assessment, and this is done every 3 years, where we bring community members and stakeholders together when we look at healthcare of the community, and bring them together to talk about what are the issues in the community, what are things that we can work with other community members, or some things that we can do as a hospital organization to address for the community. And these might be everything from needs for access to specific services we need to address.
Sure, and I know outreach is getting to be, it's a big issue, always has been, but of course in a competitive environment, lots of different areas of outreach. It's tough to know where to start, but let's talk a bit about telemedicine. Mm-hmm. So, people may say, oh, gee, what does the term really mean and how does it work? So let's start with some definitions. What does telemedicine mean in these rural communities?
So telemedicine is a broad term, and it can mean anything from an email or text exchange with a provider to a virtual visit through video secured video lines where you have a provider on one end of the equation and a patient and provider at another end of the equation. And the technology is so sophisticated now that for places that are delivering telemedicine in an emergency room or in a stroke setting, they can control the cameras down to the point where they could read what time it is on your watch. They can see whatever they need to see in terms of the patient care and be able to provide advice and guidance for the provider that's on site to be able to care for that patient. So it's a wide range of services that can be offered within the rubric of telemedicine, but the most sophisticated and the most promising are really around video.
And it strikes me that one of the issues that, of course, this touches on there is, of course, broadband.
Correct.
Because people think about broadband in terms of, well, what am I doing at home and my internet speed and how is that? But if you're a rural provider, you really need to have great broadband and dedicated broadband that's uninterruptible, let's say very high degree of reliability in order to do all these images, right?
Yes, exactly. That is so vital to the success of a program like that with telehealth or telemedicine, is you need to have that access.
Yeah.
We've referred to broadband access as now one of the social determinants of health. You know, where it used to be, did you have access to parks? Did you have safe neighborhood? Do you have access to healthy foods? Now access to broadband is right in there with the other social determinants of health. And if you don't have that access, limited information, limited access to care, limited services, and that's one of the issues that is particularly in rural communities like Minnesota and South Dakota, North Dakota, Wisconsin. Extending that broadband access is very, very important.
Sure. So you're really reframing broadband to a certain extent to say that not only is it telemedicine, but also, let's say, if you're at home and you're looking at home care options, you need to have, reliable, if you're going to check in on home care, if you're going to check in, if you're a patient and you're going to check in with a doctor or something else. So it's not just hospital to hospital or hospital to specialist, but it's individual to hospital, individual to clinic, right? All of those connections?
Absolutely. And you'll have patients that have monitoring devices in their home, whether they're wearing them or whether it's a scale or other measuring devices to monitor their progress as their provider is dealing with a chronic condition or recovery after a procedure. And all of those are being fed up through the internet. I mean, that's the access point for that information. So the ability to do home monitoring, the ability for the patient to be able to communicate with their provider and to be able to send data, it all relies on those internet services.
And a key part of that is the high upload speed and a high download speed, because often when people are looking at speeds, there's a big difference.
Yes, yes.
Yeah, fascinating. Workforce, let's touch on that a little bit, because of course there's been attention paid for decades to shortage of providers in key areas. So, in the 70s, of course, people remember, lots of ads for, bringing a doctor to town. We saw that a lot. I know one case in Kansas where they actually wanted a doctor, and he said, well, I'm not sure because you don't have a PBS station. Well, now they have one. They can get more doctors. That's my own plug. True story. But we got a PBS station here, so we're fine. But beyond that, attracting workforces. I mean, I sometimes wonder, are there situations where hospitals end up sort of competing with each other in the same area because there's such a shortage of workers? I mean, what's happening there?
Well, Jason, if you want to talk about some of your experiences in recruitment of providers.
We continuously work on that. We look at what draws people to our communities. You have good jobs in a hospital, whether it's nursing or as a therapist or a physician. There's great opportunities there, but you also want to look at what draws people to your area when you are recruiting, because that is part of what keeps them there too. And so when we look at it, we want to make sure that we have the right fit. And we know that, yes, we are limited on the number of nurses or the number of physicians that are available. We see that as a trend, and that's something that Matt can confirm too. But we also want to look at what is the long extended plan. Those physicians you talked about in the 70s that were trying to recruit to rural areas, they're your physicians that spent 30 years in that position. Well, how do we try and recruit and retain? It's easy to recruit for some areas, but how do you retain them in that area? Because you want to look at what's your long-term plan to keep those good employees, to keep the people you recruited in staying with your organization as well as your community.
And does the recruitment and retention of a quality workforce in healthcare also, to some extent, as we shift more to a millennial workforce, is that also a case where we're seeing more people who say, okay, what does the community have to offer beyond this position? What are the other community amenities? Because some of the research seems to indicate that an important point for millennials in the workforce is, I want to go someplace that looks like a great community, and then I'll figure, to some extent, what the job is, right? Are we seeing some of that?
Yes, we are. Looking at that with the millennials, they want to have that balance. They want to work, but yet they also want to have their free time. They want to be able to have great leisure opportunities, outdoor activities, or find what their special interests are and be able to address those with the community. So I think the more a community can offer in that area, the more opportunity they have to retain those employees in the community.
And by offering, we could be talking about everything from parks to theater groups to arts groups to places to eat, all of it, right?
Exactly.
Yeah, so it all comes into that broader umbrella of community development. What are some of the other things, as we think about other changes in healthcare? Of course, people who travel throughout rural Minnesota and they go down a highway and say, oh, I don't think that hospital looked that way last year. Or I thought, what's getting built there? I mean, obviously, for a time in Minnesota, we had, there was concern about hospital construction. There was legislative action on hospital, moratoriums on construction. And so what's going on with the physical plant of hospitals in rural Minnesota?
Well, Minnesota still has a hospital moratorium, so hospitals are prohibited from building new beds or expanding their beds. They can rebuild the hospital, they can renovate within their existing bed licenses. And what we saw, as you noted, was a period of time in which access to credit, access to finances for being able to do that was difficult. That has become a little bit easier. One of the biggest changes for rural communities has been the introduction of the USDA in providing loans, low-cost loans for rural communities and particularly rural health systems to be able to upgrade their infrastructure, to be able to upgrade their facilities. And that has provided a lot of rural communities with the opportunity, the affordability, to be able to both provide state-of-the-art, high-quality care at something that they can afford within the reimbursements that they have and within their community's needs. So that has really been a strong, impactful change in rural communities, is access to that funding.
And that would be through the, when we talk USDA, we're talking about the USDA Rural Development Program, or the Rural Development Division, which does things from hospital loans to infrastructure, water, sewer systems, housing, all of those things come under. So this is a piece of that?
Right, correct.
Okay. So the other thing I've wondered about with some of the hospitals and some of the redevelopment, or you have a hospital that was in the center of town and now there's a new building at the edge of town, and it's going to be serving roughly the same sort of patient base. To what extent is this also about those hospitals demonstrating to the community that we're growing, we're alive, we're getting new people here, we want to maintain the local patients, the local customers that they have? Is that also a huge part of this?
I think it is. I think it's looking at what is the commitment to the community, what's the investment in the community from those organizations that are doing that. They also probably look at a strategic plan of what are we seeing for the health of the community? How do we affect the health of the individuals in the community we serve? And so they begin to look at their strategic planning and what do they need to replace for those facilities, or what do they need to upgrade, and then working within that with the USDA or other funding resources that they have available to really make an impact in the community.
Yeah. One of the things that's unique in Minnesota, or relatively unique in Minnesota, virtually all of our hospitals are either charitable nonprofit hospitals or public hospitals. And so when they're looking at what do we need to do with our facility, where do we need to locate, what are the needs of our community, they are integrally related to their community. Their boards are guiding them on their strategic plan. They're interacting with their community to find out what their community needs. And all of that investment stays within their community, as opposed to a for-profit entity where dividends are being paid out to shareholders or whatever that may not even be in the community or even in the state. And so when you're looking at those, almost all of those decisions are major decisions for the community, a major decision for the hospital or health system, but the whole community has usually participated in helping figure out what do we need, where do we need it, how much do we need. And so that's part of that outreach that our hospitals are doing.
Sure, because it strikes me that if you have a hospital that's owned by a small city or a city-county or a city-county in combination, there are a number of those, that obviously there's going to be a high degree of public engagement because people consider it their hospital. There's a sense of ownership that you would not have if it's a distant for-profit operation, right? Yeah. So I know, Matt, earlier you talked about that there are a number of things that hospitals across the state have in common, but let's drill down a little bit to talk about the differences between rural and metro. As we look at those two different hospital models, what are some of the things that are fundamentally different for rural hospitals and that they need? And I'll just for either one of you.
I think when you look at rural hospitals, a couple of different things. You look at what is the access for resources. Your larger facilities will have more of the specialty services, and so as a rural hospital, how do we look at where are those resources? Do we have telemedicine using the specialty services through that type of arrangement, or do we look at community collaborations where you may have a physician with a specialty that's hired in one community but has outreach to the other communities that are within a driving distance, 20 or 30 miles, and that way you can collaboratively work together with other organizations to access those services. So I think, looking at that part of it, you have a lot more community development and community insight, like you were talking about, with the communities being dedicated to their hospital and seeing that and feeling ownership in their hospitals. That's something that I think in a rural community you have that sense that may be stronger than what you have in a larger facility in a metropolitan area.
Yeah. So it does make me wonder, though. You've talked about some of those things. I'm curious now if we're just going to look ahead a bit. So we've talked about telemedicine and we talked about workforce. What's next? I mean, obviously a lot of changes, a lot of construction. What's going to be the next big thing in rural hospitals? Matt, I'll start with you.
Well, I think you mentioned telemedicine, and we've talked about that. I think for rural hospitals, the next sort of big thing, and it's something that rural hospitals have been doing for a very, very long time, but it's going to be more deliberate, and it's going to be more part of their organizational core, and that is chronic disease management and care coordination for their population. Hospitals and health systems in rural communities have always had a closer connection to their patient base because they live with them, they go to the grocery store, they're in church together, and so it's easier for them to have those connections with the community stakeholders and their residents. As we have an aging population, as we look more toward how do we manage population health and how do healthcare providers play a role in ensuring that we're getting the preventative care at the front end, we're managing the diseases when they do occur, and trying to keep costs as low as possible. That's really going to be the future for healthcare, and particularly for rural communities.
Sure. Jason, is that what you're seeing? Do you agree with that? And Morris?
I would agree with Matt on that. We really need to focus on how do we take care of the communities, not necessarily on the individual basis, but like Matt was saying, on the chronic care management. Those are the things that we want to look at, is how do we integrate community partnerships in with that, not just having it be set up in our clinic or our hospital where we're providing care, but how do we reach out to the community to address those chronic care needs.
Great. On that, we're out of time. Matt, Jason, thank you very much. That's it for this week on Compass. Join us next week as we take a look at how one professor's salsa became a college entrepreneurial program and business.